In this video, we're going to look at acute cardiogenic pulmonary edema, more specifically, the inability of the left ventricle to accommodate the preload. And in order to investigate this pathology, we need to look at two types of left ventricle dysfunction that will lead to the left ventricle having an inability to accommodate the blood that's coming into it. The first we're going to speak to is diastolic dysfunction. Diastolic dysfunction is when the left ventricle becomes enlarged and fibrotic and is not going to allow as much blood into it, and is one of the typical causes of not only congestive heart failure, but acute cardiogenic pulmonary edema. So what happens in diastolic dysfunction is we start to see remodeling of the left ventricle. And we will draw this remodeling in here in brown to show that we're seeing hypertrophy. So in diastolic dysfunction, what we're typically seeing is hypertrophy of the left ventricle, or the left ventricle is becoming enlarged. So what often happens is this is a muscle that has had increased workload that leads to remodeling of tissue or hypertrophy of tissue, so the cells are becoming larger. But on top of that, what has happened is the left ventricle has also become fibrotic. So this is what's happening in the presence of increased workload with often not enough ability to supply that heart with sufficient oxygen to support that workload. So in diastolic dysfunction, we're seeing two things. One, we're often seeing hypertrophy of the left ventricles. The left ventricle is growing in size, and we're also seeing fibrosis or some subtle ischemia. So we have fibrosis or scarring of the left ventricle. So obviously what happens when we have this hypertrophy is we have increased size of the left ventricle, which means we have a decrease in space for filling. So there's not as much room for blood to enter the left ventricle. And then when we have fibrosis, the problem is that we get stiffening of the left ventricle. So the left ventricle becomes stiff, which is going to lead to decreased stretch of the left ventricle, or that's going to impair output, or it's not going to be able to accept as much blood in if it can't stretch. So there are a few things that can lead to diastolic dysfunction. Most commonly, we're seeing this happening when the left ventricle has an increased workload. So in order to get to diastolic dysfunction, typically what you're going to see is an increase in MVO2 for the left ventricle. And that could be a number of different things. If you think of the patients that you've seen in the field, one of the more common types of diastolic dysfunction is the result of atrial fibrillation. So something like AFib can lead to diastolic dysfunction. What's happening in atrial fibrillation is we're losing the atrial kick, which is going to lead to the left ventricle having to work harder. So in something like AFib, for example, so say we do have AFib and we've got these ectopic foci firing in the left atria. What happens is we don't get rhythmic contraction of the left atria. We will lose or decrease our atrial kick, which is going to decrease left ventricular filling. And if we decrease left ventricular filling, then it actually has to work harder in order to have output. So decreased atrial kick means we have decreased preload to that left ventricle or decreased left ventricle filling. So we have, as a result, cardiac output will fall and the left ventricle has to work harder. The other thing that you're seeing when you have something like AFib is we're going to have an increase in rate. So not only do we have this loss of atrial kick and the lack of filling in the left ventricle, we're also going to see an increased rate or rate increases, and the left ventricle will be stimulated at a higher rate, which is also going to increase workload. So one of the key characteristics of a pathology that leads to diastolic dysfunction is that we have something that's going to increase our workload that can lead to remodeling. So as I mentioned, atrial filling or atrial fibrillation is one of those common things. You can also see this in hypertension. So patients who have hypertension or high cholesterol, which is going to increase blood pressure. In those instances, what's happening is the afterload is high. So as this left ventricle is trying to pump against a high afterload, it has to contract much harder in order to overcome the pressure that is in the aorta because the patient has hypertension. So hypertension is another common factor that leads to someone experiencing diastolic dysfunction. We can also see this in valve disorders. So in patients who have stenosis or prolapse of their valves, we can also see an increase in workload, and that would be related to either the aortic valve not wanting to open, and the left ventricle has to pump very hard to open that valve, or perhaps the valve between our left atrium and left ventricle is not closing properly, and we're getting regurgitation of blood through that valve. So valve disorders can also lead to remodeling. And what's key to this is that these patients typically have this increase in workload. So the left ventricle has to work harder, but it's typically working harder in the presence of enough oxygen and nutrients that the muscle can grow, but not enough that it doesn't lead to some fibrosis or stiffening. So we have an increase in MVO2. Like I said, atrial fibrillation, hypertension, valve disorders are very common causes of diastolic dysfunction. And typically, these pathologies are happening in the presence of enough oxygen and nutrients so that the ventricle can grow, but not enough that we don't see some fibrosis. So that's what kind of differentiates basically a healthy hypertrophy. So I think about the athlete who has a hypertrophy of the left ventricle because they are consistently working their heart. Those patients typically will have enough oxygen to supply that muscle. When I look at someone who has, say, AFib or hypertension, valve disorders, often that's happening in the presence of some other comorbid medical problems. So say something like diabetes, they could have atherosclerosis, breathing problems, COPD, for example, that lead to a decrease in oxygenation. So we might have enough oxygen and nutrients that the ventricle can grow, but we don't have enough, or essentially not enough, that we don't have some fibrosis occurring. And these are the hallmarks kind of a diastolic dysfunction. What's happening for these patients is we have increased MVO2 for the left ventricle. So as a result, what we're going to get is hypertrophy of the left ventricle. So we start to see hypertrophy of the left ventricle, but we're also going to see some fibrosis or stiffening of the left ventricle. So we get fibrosis and stiffening of that ventricle. And a couple of things are going to happen as a result of that. If you think about what happens with hypertrophy, is we already mentioned that decreases space for filling. So as we have hypertrophy of the left ventricle, we decrease filling space. And what that means is we're going to have less blood in the left ventricle at the end of diastolic filling. So because we've reduced filling space, we increase our end diastolic volume. So this patient will actually have a decrease in end diastolic volume. So they have a decrease in end diastolic volume, which means they have less filling, and there's just less blood in the left ventricle, which obviously will mean we have less cardiac output. So because there's not as much blood in this left ventricle, I'll use pink here to depict blood. If this is the only space available, there's just much less room for filling or for blood to get in. So we're just ejecting less blood. So in diastolic dysfunction, the big problem is we have less room, which is going to equate to less blood being ejected. Hence, our cardiac output will fall. So as we have a decrease in end diastolic volume, then we will also see a decrease in cardiac output. The other piece that we should talk about is the fact that we have fibrosis and stiffening of the ventricle. As a result, that's going to make it harder to eject blood from the ventricle, or we can't have as strong of contraction. So we can see a decrease in contractility, which will also decrease our cardiac output. This is one of the ways in which diastolic dysfunction can lead to congestive heart failure. So in the chronic setting, this decrease in cardiac output will be pervasive. As we have a decrease in cardiac output, we'll have an inability to supply oxygen, and you'll basically see this process continue in a cycle until the patient ends up in late stages of congestive heart failure. So that's kind of a different process than the acute cardiogenic pulmonary edema, which is an acute presentation of someone who has a diastolic dysfunction or potentially systolic dysfunction. Diastolic dysfunction is also known as heart dysfunction that has a preserved ejection fraction. So you may have heard that previously. The diastolic dysfunction has a preserved ejection fraction. And all that means is that when we look at the amount of blood coming into the heart, we typically see the same amount or a reasonable amount leaving the heart. So ejection fraction is just, well, how much blood comes in versus how much blood is going to exit the heart. So if this much blood is coming in and we're ejecting this much blood, then our ejection fraction should look close to 100%. And in diastolic dysfunction, that is what it appears, is because the heart is trying to eject very little blood. We know that we have less room for filling, which means we have less blood. But because there is such little blood coming into the heart, typically it's not super challenging to actually eject that blood. So we have preserved ejection fraction, or the heart is usually capable of ejecting all of the blood that's in it. Cardiac output is still reduced. It's not that much blood that's being ejected, but the amount that is coming in can be ejected. So the heart can still eject the blood that's entering it. As an alternative to diastolic dysfunction, we can talk about systolic dysfunction. And what happens when the left ventricle is experiencing systolic dysfunction is instead of seeing hypertrophy, we actually start to see dilation of the left ventricle. So this is where we're having a loss of myocardial cells, or we're starting to see a decrease in myocardial cells, and as a result, the left ventricle is becoming dilated. So one of the core characteristics here is we start to see a decrease in myocardial tissue. As a result, you start to actually see increased space within the left ventricle. So the left ventricle becomes dilated, or we start to see dilation of the left ventricle. Similar to diastolic or systolic dysfunction, or similar to diastolic dysfunction, what we see in systolic dysfunction is this fibrosis of the left ventricle. So we still get this ischemia and stiffening. So we still are going to see fibrosis and stiffening of the left ventricle. But as you can see, the big difference here is that the amount of space in the ventricle is dramatically increased. As we have this myocardial tissue, the decrease in myocardial tissue and dilation, one of the other consequences to this is going to be a decrease in contractility. So whereas in our diastolic dysfunction, our contractility is a little bit impaired because of the fibrosis and stiffening. When we combine that fibrosis and stiffening with a fairly dramatic dilation or decrease in myocardial tissue in the left ventricle, we have a dramatic reduction in contractility. So we start to see a huge increase in space. So if you look at filling in the left ventricle when someone's experiencing systolic dysfunction, much more blood can enter. So we have much greater room for filling. So you start to see an increase in our end diastolic volume. So because so much blood can make its way into the heart, we typically see an increase in end diastolic volume. But where that is countered is because we have such a dramatic increase or decrease in contractility. So because contractility is decreased so much, our output falls, or our ability to eject this end diastolic volume is greatly impaired. So this decrease in contractility really greatly decreases the ability to eject the EDV. Or it's hard to get all the blood that's getting into that left ventricle during diastole out of the left ventricle. And in systolic dysfunction, we do not have a preserved ejection fraction for this reason. So unlike what we talked about with diastolic dysfunction, this patient will have a reduced or a decreased ejection fraction. So how do we get this? How does someone end up with a systolic dysfunction over a diastolic dysfunction? The causes are really quite similar. So we usually see an increase in MVO2. So something is causing the heart to demand more oxygen. So something's increasing the workload on the heart. As I mentioned before, this could be dysrhythmia. So things like atrial fibrillation are common, hypertension, valve disorders. And on top of that, what we often see is that this patient will have some degree of acute coronary syndrome as well. So patients who have systolic dysfunction often will have had a heart attack or may have progressive or consistent angina, which is really challenging the amount of oxygenation that this heart can get when it has to work harder. And that's the other key feature to systolic dysfunction. Is remember when we talked about diastolic dysfunction, we talked about the heart getting enough nutrients that it could grow and could become fibrotic. So we're still having some hypoxia or some ischemia, but we're still getting enough nutrients or oxygenation to this tissue that can grow. So it's growing. It's not growing well, but it can still grow. What's different in systolic dysfunction is there are not. So the patient does not have enough nutrients or oxygen to support growth. So think about a patient who maybe has severe COPD or has a really bad atherosclerosis, then this patient may not be able to support the growth of the tissue. So there's not enough oxygen or there's not enough nutrients for the tissue to grow. And as a result, we just see progressive damage of the myocardium. And that's how you can end up with this dilation or this decrease in contractility. So this is the key feature. And again, much different than when we're looking at diastolic dysfunction, is in systolic dysfunction, there are not enough nutrients or oxygen to even support that growth, so the tissue will just continue to dilate. A lot of instances, what will happen to patients is they'll first have hypertrophy of the ventricle. So as they do have enough nutrients to support growth, we'll see some growth. And then as that ventricle continues to grow and demand more, then they won't be able to support the growth or the growth with nutrients or oxygen, and then the ventricle will dilate. So what's happening in this case is we're having dilation or decreased muscle tissue because we just can't support its growth or its ability to sustain itself. So what happens is that's where we get this dilation. So if I don't have enough nutrients or oxygen to support growth, we start to see destruction of our myocardial tissue. And as we have the destruction of that myocardial tissue, what's going to happen is we will have dilation of the ventricle. So as we start losing the myocardial tissue, we start to get dilation of that left ventricle, which means we're going to increase space for filling. So one of the consequences of this is we start to get increased space for filling, or we know that that's going to be known as having an increased end diastolic volume. So one of the things that we'll see for this patient is an increased EDV, or there's more blood in the left ventricle following fill or diastole. The other problem is that as we have destruction of the myocardial tissue, we will have a reduction in contractility. So the patient's contractility goes down and they can't eject as much blood. And when we combine that reduction in contractility with basically increased filling or an increase in EDV, what we start to see is basically a lack of ability to eject the blood that's entering. So to eject all the blood that has filled the left ventricle. And that's we're going to see that as an increase in end systolic volume. So lack of ability to eject all of the blood that has filled the left ventricle, or essentially we're just going to have blood left over. We increase our end systolic volume, or the amount of blood that's left in the left ventricle after contraction. So we see an increase in ESV or end systolic volume and a decrease in cardiac output. Just like we talked about with diastolic dysfunction, this will be cyclic. So if I'm going to reduce that cardiac output, then I'm not going to be able to supply the oxygen we need, or our workload's going to go up. And as a result, this will just continue to get worse. Again, this is how this patient basically progresses towards congestive heart failure, or a chronic condition like congestive heart failure. So to recap, the problem with systolic dysfunction is not only that I have something that's increasing workload, I just can't support that workload. So either, like I said, my muscle has already hypertrophied, and now I've kind of gone past that tipping point of what I can support, and I can no longer supply the oxygen and nutrients, and I start to dilate. Or that's the process from the beginning, is I have an increase in workload, I have some comorbid medical problems, so something like acute coronary syndromes, atherosclerosis, COPD, malnutrition that's preventing my ventricle from growing, and as a result, the muscle tissue is slowly chipped away at, and I get this dilation of the left ventricle. The big problem with that is I lose contractility. So first and foremost, if I have a thinner walled ventricle, then I can't have as strong of contraction. The other problem is if I have a thin walled ventricle, I can get a lot of blood in here. So I can support the basically filling with a lot of blood, but I have a very little ability to get that blood out of the left ventricle. As a result, we're going to see this increase in end systolic volume, or the amount of blood that just consistently remains in the heart, and we actually see a decrease in our ejection fraction. When we look at heart failure, as ejection fraction falls to around 40%, that's when we start to see our symptoms of heart failure developing. And these patients are at very high risk because of the amount of blood that can be left over in that left ventricle, or because of this ESV. They're at very high risk of developing acute cardiogenic pulmonary edema, and we'll explain why. Next, we'll take a look at how different types of dysfunction can actually lead to acute cardiogenic pulmonary edema. So how we can actually see a patient having an decreased ability to accommodate the preload, which is our definition of acute cardiogenic pulmonary edema. So the left ventricle cannot accommodate the amount of blood that's coming into it. And as a result, what we'll start to see is congestion behind that left ventricle. So when you're looking at something causing acute cardiogenic pulmonary edema, typically the patient has a triggering factor. So in order to actually have acute cardiogenic pulmonary edema, usually we have some sort of trigger. And this trigger can be either exertional or it can be fluid related. So often we can see an exertional or sympathetic nervous system related trigger, or we can see a fluid related trigger. And what we mean by that is that either the patient will have too much fluid, which is causing the congestion, or the patient will have an increased sympathetic nervous system response, whether that be through anxiety, exertion, fear. And what's going to happen in those cases is we get the sympathetic nervous system response, which is going to impact workload and the amount of blood returning to the heart. So let's use the example of the sympathetic nervous system first. So we'll say the patient has a sympathetic nervous system trigger. And we'll say that that trigger in this case or in this example is going to be exertion. So, for example, a lot of patients with congestive heart failure will have acute cardiogenic pulmonary edema on exertions, whether that be walking around their apartment while they're attempting to have sex, if they've had a fall. So those are common actual triggers to ACPE. So we'll use exertion as the trigger. And we know that during exertion, one of the things that's going to happen is the patient will have an increase in sympathetic nervous system response, or the sympathetic nervous system will be active. So during this exertion, we start to see increased function of the sympathetic nervous system. So an increase in sympathetic nervous system response, which is going to do a few things for the patient. One is it will increase their heart rate. So we'll see the increase in heart rate. So as the sympathetic nervous system activates, it will activate our beta receptors, and we will see an increase in heart rate. The other thing we're going to see is the sympathetic nervous system is going to activate our alpha receptors, and activation of alpha receptors will lead to vasoconstriction. And if we think about what that means for the patient, we're going to see a couple of things, especially with this vasoconstriction. First is that the patient is going to have an increase in blood pressure. So we start to see increased blood pressure systemically. So we see an increase in our systemic blood pressure. And as blood pressure increases, one of the other things that we can start to see is an increase in return or blood return to the heart. So we see increased blood return to the heart. The other thing we should mention is this increase in blood pressure is often associated with an increase in afterload, or basically the amount of force that the left ventricle must contract against. So let's draw that in here first. So in the exertional setting, we have an increase in blood pressure, which is going to increase the patient's afterload. When we're talking about systolic dysfunction, like we've drawn in here, so remember we've got this dilated left ventricle. Someone who has systolic dysfunction, what's challenging about this is that they don't have a lot of contractility. We've already seen a reduction in contractility, which means that we can't have enough, it's very challenging for the heart to contract strong enough to eject blood. And as a result, as that afterload increases, we actually start to see our ejection fraction decrease. So as afterload increases, ejection fraction decreases as the left ventricle cannot overcome the afterload, or can't pump out enough blood, or can't generate enough pressure to eject a lot of blood. So ejection fraction actually decreases because we have a weak left ventricle. So an increase in afterload often will lead to a decrease in ejection fraction. So we'll call that EF, so decrease in ejection fraction. And what's going to happen there is the patient's actually going to have an increased end systolic volume. So we see an increase in end systolic volume. The other consequence is, remember we said we'd have increased return to the heart. So as the patient has this increase in blood pressure, and we're seeing increased preload, we're going to start pushing more blood into the heart. So that will increase our end diastolic volume. So now we get more filling. So if we have more blood returning to the heart, we see increased filling. And we know one of the challenges that we have is we have this decrease in ejection fraction. So not only do I have increased filling, I'm trying to eject more blood, which I can't. So I'm going to have a fairly dramatic increase in end systolic volume. And that's where the problem comes into place in patients who end up in acute cardiogenic pulmonary edema, is that we draw in what this actually looks like. So let's take a look at the heart when we have this poor ejection fraction, increased filling. Say we have the heart is filling quite substantially. So we said we have this increase in end diastolic volume. So lots of blood's getting into the heart. We have contraction. So let's say the heart is going to contract, but it can do so poorly and it's having a hard time getting over this afterload. As a result, we can't get a lot of the blood out. So what's going to happen is we have a lot of blood remaining. We have a lot of blood left over. So what we tend to see when patients are entering acute cardiogenic pulmonary edema from systolic dysfunction is we have an increase, or we start to see increasing end systolic volume, or the patient is retaining a lot of blood after contraction. If you think about what happens when I have an increase in end systolic volume, is we're going to decrease cardiac output, and this becomes a cyclic process. Now the sympathetic nervous system says, what the heck's going on here? I need to try and make sure that I get more blood out of this heart. We're not getting any more blood out of this heart. And it's going to start the same process over again. I'm going to have a surge or a release of catecholamines, which is going to stimulate an increase in heart rate, cause vasoconstriction, try to pump more blood back to the heart, increases afterload. So the next time I try to fill with even more blood, and I get more blood in the heart, but I get more left over. And this becomes a cyclic process until we get to a point where the heart cannot accept, or the left ventricle is so filled with fluid, it has a really hard time accommodating any more new blood. And that's when we start to see this congestion behind the left ventricle. So decreasing cardiac output and a increase in end systolic volume eventually is going to lead to no space to accommodate new preload. So there'll be too much blood retained. So any blood that's trying to get in can no longer get in. So no space to accommodate new preload. And that's how we end up in this cycle that then leads to acute cardiogenic pulmonary edema. So if we think about what is happening, or what's happening in acute cardiogenic pulmonary edema, is that I have no space to accommodate new preload. And if that is the case, what starts to happen is blood will first congest in the left atria. So you start to see increased congestion and pressure in the left atria. And this is just going to continue to build backwards, or congestion will move up, or we'll see it flow backwards into the rest of the system until we have nowhere else to go. So first you get this congestion and pressure in the left atria. If we can no longer accommodate blood into the atria, we start to see this congestion and pressure building in our pulmonary vein. So you start to see the same thing, an increase in pressure or congestion in the pulmonary vein. And then eventually we're going to end up in the pulmonary capillaries. And the pulmonary capillaries are thin-walled. And as you increase congestion and pressure in the pulmonary capillaries, the only next place to go is for that fluid to shift out. So you start to see increased pressure in the capillaries. And what happens next is fluid starts to shift out of the capillaries and into the surrounding tissue. So this is where we start to see blood and fluid building up around the alveoli. In very rare circumstances, if you were to meet this patient as this was happening, this is where you might hear a cardiac wheeze, or a wheeze as fluid is pushing in on the bronchioles and the alveoli and creating turbulent airflow and creating wheezing. But that's usually a very specific point in time, because as soon as fluid starts to build in basically the interstitial space between the capillaries and the alveoli, it's a very short period of time before fluid starts to shift into the alveoli themselves. And this is where you would see those typical symptoms of fulminating pulmonary edema, coughing up a clear or red tinged sputum, hearing bilateral crackles as the lungs actually fill with fluid. And we know that will happen in a gravity dependent way. So we actually start to see fluid filling the lungs, or filling these alveoli, as pressure builds so high that it starts pushing out. One of the other problems with this is as the patient becomes hypoxic, the sympathetic nervous system is activated even more. So this will be a consistent process, or it's usually going to get worse, or cyclically going to get worse as the patient is impacted by their hypoxia. So what we end up seeing as we have no space to accommodate the preload, that's when we get congestion behind the left ventricle, and that leads to fluid shifting into the alveoli. So we start to see congestion behind the left ventricle, which will again culminate in fluid shifting into the alveoli. And that's where we get those typical signs and symptoms of acute cardiogenic pulmonary edema. We can do the same thing, or we can highlight the same process when we look at something like fluid-related causes. So what's going to happen in someone who has a fluid-related cause is maybe they've stopped taking their diuretic, and the body is consistently going to activate compensatory mechanisms. So in a fluid-related cause, and again, most commonly what we see in these patients is they stop taking a diuretic. So say the patient is on ramipril and they stop taking their diuretic, which is going to promote basically them to urinate. This patient has impaired cardiac output. That's kind of the hallmark of all of this, is they have ventricular dysfunction that's led to a decrease in cardiac output. So as a result, the body's natural compensatory mechanisms are going to be to retain fluid. So if you stop taking a diuretic, compensation can work as it's meant to. So what that patient is going to do is they are going to release things like ADH and activate their renin-angiotensin-aldosterone system. And those two things are going to promote fluid retention. So the diuretic is acting to essentially act against those mechanisms. Well, if you stop taking the diuretic, then the ADH and RAS will act normally. You will retain lots of fluid. So ADH and RAS acts normally. The patient will retain fluid. Again, they're going to retain sodium. They're going to actually put aquaporins into the kidney to reabsorb water. And think about what happens as the patient retains fluid. They're going to lead to an increase in blood pressure. So if I retain fluid, my blood pressure goes up. And if I retain fluid, the amount of blood returning to my heart, or my preload, goes up. So they end up in the exact same position. And this can be a combination of those two things, depending on what the patient's doing. So this is how someone in systolic dysfunction could end up with acute cardiogenic pulmonary edema. So what about diastolic dysfunction? Remember, when we talked about diastolic dysfunction, we're talking about a left ventricle that is larger than normal. So it's hypertrophied, it is stiffened, and we don't have a ton of space in it. So one of the core differences here is that you have this large ventricle that has extensive fibrosis and stiffening. The tissue is large and it doesn't allow for a lot of fluid to enter. So the challenge here is not necessarily that we have too much space and not enough contractility. Our contractility is generally enough. We just don't have any space for filling. So the big problem that you can imagine is in either of these cases, so just as we talked about, we have exertion or we have a fluid-related problem, is when I promote fluid return to the heart for this patient, they are in big trouble because they don't have the room to accommodate that fluid. So when someone has diastolic dysfunction, the triggers are often the same. The patient is going to have either a sympathetic nervous system response, so again, that could be exertion, stress, or they're going to have a fluid-related problem. Either their fluid intake has been too high, or they stop taking a diuretic, their kidneys are failing, and they're retaining too much fluid. So the bigger problem for someone with diastolic dysfunction is the fact that they're going to have an increased blood return to the heart. So the increase in blood pressure and the increase in afterload will have some effect here, but the bigger problem is they have increased blood return to the heart. And the issue is that they don't have room to accommodate that blood. So there's already a dramatically reduced end diastolic volume, or the ability to support blood in the heart. So we know we already have decreased room for filling. So when you increase blood return to the heart, you can't accommodate, so cannot accommodate incoming afterload or incoming preload. So as the patient becomes fluid overloaded or they're just returning more blood to the heart, they can't accommodate the incoming preload. And the same thing is going to happen. If they can't accommodate that incoming preload, we're just going to start seeing pressure building behind the left ventricle. So as a result, you see pressure build into the left atria, up into the pulmonary vein, into the pulmonary capillaries, until fluid starts shifting out of these capillaries and into the interstitial space, into the alveoli, and the patient is going to present with what we know as acute cardiogenic pulmonary edema. So we can't accommodate the incoming preload, which is going to lead to increased congestion and pressure behind the left ventricle. And eventually, again, that's going to basically culminate in fluid shifting into our alveoli. So those are the mechanisms through which we can see systolic and diastolic dysfunction occurring and how they actually lead to acute cardiogenic pulmonary edema.